informal. Um, we definitely want to support our users and make sure that this kind of information gets to people. I know that when you take the Dawson courses, a lot of times what happens is there's a lot of information at once, and you don't necessarily get everything all the time. Basically, this is how it's going to go. I'm going to turn the presentation over to Steve, and Steve and Raj are going to have this conversation. This is a presentation that they've done in the past, and it's very interesting topic, especially now. But we want to encourage participation. So again, put them in the chat, and I'll answer them, or we'll answer them. We expect this to take about 45 minutes, and at the last 10 minutes, I do want to show new functionality that's coming into Smile Wizard with some caveats. So with that, I'll turn it over, sorry, to you, Steve, and you can share your screen.
Right, Travis, get a nice glass of water and please feel free to interject with any questions and comments. And I guess what Raj and I guess we'll keep this kind of informal. And so we really want you guys to ask questions and participate. Let me share the presentation here. Brief, and Raj, feel free to interrupt and comment along the way. I think one of the biggest things that I hear, and I guess I'll get into the introduction of both of us next, but the topic tonight is really, the question that seems to come up at every study club, at every course is how do you go from that new patient exam into records? I think that seems to be a very prominent topic that people, I guess, new coming out of the Dawson Academy, and those that are currently going through the curriculum there always have these basic questions of where do we go next? How do I take what I've learned and how do I apply this? And so Raj is a great person to talk to about this. I have some background, but kind of going through this, I just want to make some introductions. Raj, do you want to give a little bit about you? I know
Yeah,
a couple of
sure.
things, and then I'll talk about me.
All right. Thanks, Steve. Thanks, Travis. I'm a general dentist. I know sometimes people think I'm a prosthodontist or something like that, but I am not. I am a wet finger general dentist. That just happens to have gone through the Dawson Academy about 20 years ago. One of the things that I think has been amazing in my entire career is that I actually implemented it. Having taught with the Dawson Academy now for about 15 years, it's amazing how many people will learn this information but struggle in one way or another and how to implement it in their office. So I had a general practice. I had bought a general practice from a retiring general dentist that did not do a lot of complex restorative. And having gone through the academy, I realized that a lot of patients needed this sort of treatment. And so I just figured out ways to talk to patients about it and to get it done. Sometimes a little slowly, but we got the work done. So yeah, so that's pretty much it. I'm just a regular dentist that just happened to be able to implement this curriculum.
And Raj is senior faculty at the Dawson Academy and the director of the Dawson Academy Northeast, the New Jersey location. So my story is very similar to Raj's. We found that out when I went through the Dawson curriculum in New Jersey. That's where I met Raj. I finished up right during COVID. I'm a general dentist down in Savannah, Georgia, originally from New Jersey. Similar to Raj, I purchased a practice from a dentist who became ill and had to retire. And so that practice, though he was Pankey trained, was kind of dwindling down a little bit. And so how to rebuild this. And when I first purchased a practice 15 years ago, I started the academy, and then due to just financial and other issues, I couldn't continue on. And X number of years ago, I said, hey, I'm going to do this Dawson Academy. I'm going to go through it. And went up to New Jersey, did the mini residency there, met Raj, who has kind of became my mentor along the way through this. And through that, I became a scholar of the Dawson Academy, a study club leader for the Dawson Academy, and just an active member of the Dawson Academy. And I think I practice just bread and butter general dentistry like everybody else, just have a different way of viewing things now than I did years ago. So with that, Um, I think the one thing we talked about previously, Raj, was this relationship-based practice and how one develops that. I don't know if you want to give a little feedback on that, but how
Sure.
it's a little different than kind of some other practices out there.
Absolutely. And I use these words intentionally because a lot of practices out there want to call themselves comprehensive or total care or something like that, which may all be true that they offer a lot of services, maybe multiple different specialists in the house. They can do complex treatments, complex dental care. I've seen every single name out there for a type of practice. But I think what sets apart Dawson style practices and the really high end cosmetic restorative practices or functional practices is that they have a tendency to be relationship based. The general practice or even the high level practices that are all around us very often are transactional based. They might have a good rapport with the patient here and there, but basically you come in with a problem, they have a solution, they have everything set up to be able to take care of solutions. Where I think we set ourselves a little bit apart and where I think we get some success is truly developing a relationship with the patient. And we are kind of their confidant for a lot of their issues, and we are their co-navigator through solving their problems. And that's not just me, that is our entire team. We kind of treat them like family in a way. And it goes straight back to Dr. Dawson's acronym WIDIAM, Would I Do It On Me? We treat them how we would want to be treated. And so that's worked very well for us. And it's gotten us some success in conveying messages to patients and the need for treatment without trying to say that, there's a fire that has to be put out. And we got to get this done now. But yeah, so it's a little bit different in that there's a co-diagnostic process, and we decide together to enter upon treatment.
Right. And so when we talk about this relationship, and you touched upon it, when we talk about this whole idea of this relationship-based practice, it's really where the new patient enters a practice, where everything begins, right? So, you know, again, this all goes back to converting patients into records, into further treatment. And, I'm going to jump around a little bit, I think, from where the presentation goes, but it all begins with that first phone call to the office, the how your front office handles the call, the screening questions that are asked. These are all things that, play a role in determining if the patient is the right fit for your practice, and or if are they just looking to get a tooth extracted and get out of pain and not looking to further treatment. What are you looking for in your practice? It all begins with that initial conversation. And so, like you said, the first steps are, it comes back to your team, right? The team is a
Absolutely.
key approach to, this comprehensive practice, this ability to get patients and transition them into further treatment.
Steve, you hit upon a good point there. There are a lot of patients that come in, maybe wanting one thing or the other, but the way my team handles the phone, specifically my office manager, Danielle, it's just amazing how she talks to them about their concern, why they want to come in, why they're even considering seeing us, whether it's, pain or whatever the situation is. She validates all of their issues, lets them know that they're going to be cared for. And oh, and by the way, he's going to look at things as to why this might have happened, so it doesn't have to necessarily happen again. And so there's little conversations like that being had, sometimes even before the patient walks in the door, and as they're filling out the paperwork and getting registered at the office, she's having these conversations even before the patient's coming back to see us. So it really does start with the phone call, and then it continues as soon as they walk in the door. We have some right there greeting them and welcoming them to our practice, basically.
Right. So that initial phone call, that front office person is very similar in my office. I have somebody who has been through all phases of dentistry as my front office. The first voice you hear. And it's really important that, you come back from these courses, you come back from these classes, and, I always would say when I come up and I talk to students going through the academy that, you want to come back from each course practicing one, two, three things, not just the clinical stuff, but some of the other things you hear, and getting the staff on board, getting your team to, understand where you're transitioning your practice to, or what you're starting to do is really important, because you're not answering the phone. 90% of the dentists out there aren't making the appointments and answering
Usually, yeah.
answering the calls. So, if your front office has that ability to screen, I guess is the best way to say it, to, you know, ask those specific questions to determine what the patient is looking for, and explaining your philosophy in a way of how your practice works, that's kind of key to this whole process too.
Absolutely, and it kind of lets us have a kind of a workflow or a flow chart of how they come into the office. Now, if they have like a pain, sort of something that's bothering them so much, we Danielle and the front office team, they definitely know that to validate the patient that we will definitely improve upon whatever your situations. We will address that. If it's just an emergency, then we still ultimately want to get them to a comprehensive exam. We're just not going to do that on that first visit necessarily. We might have some conversations about, why this happened, why this tooth broke, why, whatever it might be. But we'll take care of their primary concern. We're just not going to go on to doing definitive dentistry yet. We're just going to basically treat the urgency and invite them back, hopefully for a comprehensive exam, and hopefully in all of what we've done so far, and the conversation that we have at that time, based on whatever situation they came in for, we're hopefully compelling them to go over to that comprehensive exam. I think I went forward on the slide. I think we have that on how.
You're fine. I know we're kind of jumping around a little bit, which is fine because this is how
I
this
just realized that.
go, right, Travis? We're kind of just let this go. But so, which leads me to a question we constantly get, we are constantly hear from new Dawson dentists is, how do you do your comp exam? Some people have been going from, the new patient comes into the office, they get a cleaning, then they see you do a comp exam. How do people do it? In my office, it's kind of similar to what you said, Raj. Urgent care is treated urgently and palliatively and get them comfortable, take care of the situation, and ultimately bring them back. I, coming out of the Dawson courses, I transitioned to a 1 hour comprehensive exam for all new patients prior to them getting a cleaning. And again, it's not a full hour with me. We do our records, we get our photos and our iTero scan and our x-rays, and maybe it's 25 minutes with me in the room, depending if I am in a talking mood and I'm in there longer, patient. But we explain to the patient that as a new patient coming in, we don't know what your periodontal status is. We don't know where your gums are or how healthy you are. We can't just clean your teeth. And, what type of cleaning? This is the questions the front office is like, we'll say when they say they need a cleaning, well, we'll say, what type of cleaning do you need? And they say, what do you mean? And so, these are those probing questions that lead to the comprehensive exam where, besides getting some base records, we do our full comprehensive Dawson exam. And in my practice, that includes using Smile Wizard. So all new patients coming in get that full Dawson comprehensive exam. The Smile Wizard is open on the computer behind me. My staff has already asked and answered, put the answers in for all the questions that they can do prior to me even coming into the room. So really, I'm doing the clinical side of things and kind of, gathering that other information that they are not getting.
Steve, I just want to chime in. So in our office, it's pretty much the same thing. But once in a while, we just have that patient that wants a cleaning. So when Danielle in that phone call if she's basically gotten the understanding that that patient's primary concern is they want their something cleaned up, they have an event or something like that, we will schedule with the hygienist. I mean, my preference is to have a comprehensive exam without an emergency being associated with it, and just me having between me and my assistant having that hour with the patient. It just doesn't always work that way. I'll describe a situation that happened today. A new patient came in on a referral from a family member that had been in the practice, I guess, for a few months. She came in and she was in hygiene first because it worked in the schedule. It was templated that way. But she was willing to stay also to see me for a comprehensive exam. So we were able to do it so that it wasn't like a period. If somebody's just going to get into hygiene and that's really all they want right now, I'm not going to do a comprehensive exam on that visit. I'm not going to bill it as a comprehensive exam. I'm not try to squeeze it in to the hygienist's schedule. It's not fair to her or me. So what I would do is a periodic exam and hopefully invite them back in the periodic exam. To display the need and compel the need for the comprehensive exam and then bring them back. In this patient today, this new patient, she was willing to spend the time. She just really wanted her teeth cleaned, so it happened to work out that she saw the hygienist first. If somebody comes in just for hygiene and has not committed to doing the comprehensive exam with me, my hygienist also knows all about this and will hopefully compel the need for a more thorough evaluation, or I will do that with the patient if I go in to see them, which I always will. But once again, we try as hard as we can in the phone calls beforehand to get them into the template that we like, which is the exam with me, and then whether hygiene's the same day or we call it a hygiene evaluation because we never know what the level of care is necessary, and my hygienist will then help to figure out, how many visits we need. Is it one? Is it, whatever it is, a scaling. But we try as hard as we can to bring that patient in for a Smile Wizard comprehensive exam on that first visit. If it doesn't happen that way, it's going to be the second or the third time visit I see them that we're doing that exam. We're not doing anything definitive until we've done it. That's for sure.
Right. I agree 100%. That's how we kind of do things. There are those outlying patients that come in for the cleaning and so on and so forth and need in. And definitely, if the hygiene room is there and it's open, I want my hygienist to be busy. So, if I can put somebody in there. The nice thing about that too is she's planting seeds, right?
Yeah.
We talk about expressing concern, which is the slide I wanted to lead to after talking that is, it's the team. I guess everybody always hears that when the dentist says it, it's sometimes like, oh, you're trying to sell me so you can pay for your boat and your house and this and your vacation and all. But when you have the staff kind of pointing it out to them, it's kind of different, right? When the assistant is saying, or when the patient turns to the assistant and says, is that true? And the assistant can say, yeah, look, you have the wear here, you have this sign of instability, or the hygienist is pointing out mobility and migration of teeth. It just leads to more of a concern by the patient, no?
Absolutely, absolutely. So I'm going to refer back to another example of a new patient yesterday. Came in on an emergency, chipped a front tooth, and wanted something bonded. And my assistant, who took the initial photo, it's like even on an emergency, we're going to take some photos, at least a handful of photos. Depending on the emergency, we'll take different amounts, but we take photos. We take an X-ray of the area, and then she's talking to the patient even before and said, he's not going to fix that tooth, just so you know. Because she knew I couldn't. Having been with me long enough, she saw the rampant occlusal disease that the patient had. And I walk in and I had to translate it. She had to translate into Spanish. And so I was just like, if you ask me to do that, the reason I won't do it is because basically it's going to break by the time you get to the parking lot. It's just not going to work in her situation. Unfortunately, it really truly would not have. Once in a while, I'll try to repair something for somebody if and when I can to make them feel better about themselves. But this one, I really couldn't. I was just like, it's just not going to work. So, but she expressed the concern with the patient and said, this is why he'll be worried. I expressed the concern, but it's that true compassion and concern for the patient. And I think if you feel it honestly, I really do think they can tell. That new patient I had today, I started having this conversation. We did the Smile Wizard exam, and she was kind of like a little bit overwhelmed by how thorough we were because she never expected anything like that. And I just stood up, sat her up, and I looked at her, and she goes, so I guess I have some stuff going on. And we hadn't even like looked at the photos, and then we were about to do a scan. And I was like, well, yes, there are some things that are concerning me, but this is the first time I'm seeing you. I have not seen you over a period of time. So I don't want to, sound the alarm, but I am a little bit nervous about a few things. And then I went into the detail about what I was nervous about. And I said it was that expressing. That's exactly what I did with her. I expressed the concern on based on my exam of what I was seeing.
And I will say you hit on a point that I have seen now for a couple of years is when you do a Smile Wizard exam, when you follow that Dawson clinical exam, that if you want to call it that checklist, that protocol, that first stage in the Smile Wizard, I have not had a clinical exam where the patient at the end has said to me, nobody has ever done this to me. Nobody has ever spent this much time with me. Nobody has ever done such a thorough exam before. I hear that constantly.
It's like on repeat, right? Every single time we get to this, whether it's visit one or visit two or visit three, it's amazing. It's just like music to my ears every single time I hear it.
And the thing about it is, with using Smile Wizard, you're always doing the same thing because you're
Yeah,
following this flow chart, right? You're following this list of how to do things. And so, and it's great because as I'm doing it, as I'm saying things, my assistant's behind me putting it into Smile Wizard. It's all
right
there.
in. Yep,
So, if you want to do a great comprehensive exam, I mean, it's basically just following these basic protocols. Um,
absolutely.
and it's funny, I had a similar patient, not to kind of on a tangent, but similar patient with a chipped front tooth. Actually, a friend of the family's came in and she sat down and my assistant said to her the same thing. He is not going to fix this. And I sat down and I said, and I know her, so I was more, straightforward. I said, there's no way I'm fixing this because you're going to break it. We talked about occlusal issues and, she needs to move teeth first. I mean, that was just very evident. And so, boom, that went to Invisalign. And then from Invisalign, she said, well, I think I might want to do veneers. Well, I said, then we'll get some records after. So this is a great segue of how we transition patients from this comprehensive exam to records. And I think one of the things that students come out of the course, so eager, so gung-ho to get records, to get everybody into records. Not everybody is going to go to records and not everybody's ready to do treatment at the time.
Absolutely. Actually, sometimes we have patients who we've gone through the exam, we've seen all the problems, we have some photographs, and it just hasn't gotten internalized yet. Maybe they got a lot of things going on in their life, personally or professionally or whatever it is, and nothing is hurting, and that there's no thing that's urgent. And I'm not going to sit there and scream at them and force them to do something that they're not ready to do. So I just, I'm honest about it. I tell them, I don't know if and when it's going to be a problem, but I can tell you, just having practiced long enough, it will eventually get worse. If there's a problem in between now and the next time I see you, just let me know. But the next thing I'm going to need is a little bit more time with you, if you don't mind, so I can study what's going on, and so I can give you the simplest, best option to correct it. And that's kind of how I leave it and I walk out of the room.
Right. And
um,
I think that's kind of similar to what I do. And I think it's just planting those seeds, right?
yeah,
They come in for the hygiene exam, the hygienist is saying things before I'm in there. I'm coming in and for me, it's like when you're ready to address these concerns, I'm here to talk to you about it. I'm
yeah,
here. And, I think you have a number of great, little like we talk about finding this common language, keeping it simple,
yeah,
kind of relating to the patient, depending on what they work on or who they are in their background, you can kind of find different things to kind of relate. I always tend to use the foundation of a house and pulling bricks out when I'm talking about extracting teeth and how, when you pull a brick out of the foundation, everything collapses, you extract one tooth. If we're not talking about how we're going to replace that tooth,
oh,
what's going to happen to the foundation being your occlusion. The bricks are going to shift, the teeth are going to move, things are going to happen. I try to find that common language. I try to keep things very simple and very plain but not be too pushy, and I find that some patients once they hear it, maybe the first time, maybe the second time, are start asking the questions. And then
Yep.
the reply to them, my reply is sometimes is, I need to get some more information to sit down with you to explain to you how we can correct this problem. And that is the transition to records for me.
Absolutely. And I also I use different analogies than your house analogy. I love that though. I think that's great. I use car analogies. If not everybody understands every detail about a car, but I talk about very simple things. If there's an overall orthodontic arch form issue, arch size discrepancy, or tooth angulation issues, I will talk about alignment. I'll say, have you ever driven a car where you had to turn the steering wheel a little bit to the left to go straight? And a lot of people have, not everybody has, but I said, so your alignment's off and that needs an alignment. And I said, have you ever had to have a tire changed on a car? Is it because the treads were bad? Is it because you popped the tires? Is it because the pressure is really off? And so I use car analogies to explain the balance of the tires, the balance of the car, the balance of how the bite comes together, the overall alignment. I like that analogy. I also use wobbly tables. Have you ever been at a dinner table that wobbles? You don't want your drink to fall over. So how do we get that table stable? So just simple things like that, things that people can resonate in their head and create a little mental picture of, oh, I know what he's talking about. It's like when it comes to cars and tires, I said we got 28 tires in our mouth here, and so we want them all to work together properly. If the tires on a car aren't perfect, the car will still run. It just might not run well. So
Right.
Okay, I got a quick question for you guys.
Yeah. Yeah.
Um, let's say how many of these types of patients, and let's just take money off the table for a second. Let's say you do all your work for free. Let's say you have 1,000, or no, not 1,000. Let's say you have your next 100 new patients come into the office. What would you expect? How many of these people would probably need to do a complete exam?
all of them,
Well, exactly. Everybody gets a complete exam.
everybody needs it.
Everybody needs it.
Everybody needs it
And
without
so,
question.
and once you've established kind of their own baseline by doing the complete exam, and if that's 100% of your patients, then you're probably discovering deeper treatments than you otherwise would have, if you're not going to do the complete exam, correct?
Absolutely. And we may not, as Steve just said, they might not be ready to do the records yet. They might be ready to do the records in 6 months, 12 months. They might be ready for solutions, in other words, a little bit down the line. I had a patient come in for actually an emergency on Monday or Tuesday, I think. And I did the comprehensive exam on her, blew her mind away about 3, 4 years ago. She actually came in for records, and for whatever reason, timing wasn't right. She didn't do anything. I think she just didn't realize the real reason why we needed to do it. I messed up somewhere. She came in on an emergency the other day. She looks at me. I took care of the emergency. I looked at her. She goes, "This is all that stuff you talked about a few years ago, isn't it?" And I was just like, yeah, it is, Nancy. And I said, I'll do whatever you want me to do, but this is why it happened. She goes, yeah, okay, I think I'm getting ready to do it.
So
And that
yes,
was,
some people realize it right away, and some
yeah,
people it's a year or two for them to realize it, and some people realize it, they just can't afford or
yep,
aren't mentally and financially there to do it at this time. And so,
yeah,
I think stabilizing things, I mean, that's where we get into doing occlusal guards and splints and things like that to, that's always my backup is like we can band-aid the
yeah,
situation. We can put a
always,
band-aid there. That's what your splint is. It's a band-aid. It's going to prevent it from getting worse, but we still need to address why it got there and why it's this way.
yeah,
And I think, Travis, going back to your question, I think for somebody new coming out of the Dawson Academy, at least with my experience, and Raj has a lot more experience than I do, but I think realistically, 1 to 2 record patients a month, if you can convert 1 to 2, I mean, initially it's a
that's
lot
all.
of time. It's a lot
Yep,
of time to sit down and go through it, and especially when you're coming out or you're in the scholar program, you still have a lot of questions. You don't have all the answers yet, or you're new and you kind of just need to kind of wrap it around. You start doing 4 or 5, 6, you're just going to backlog yourself. And so
Absolutely.
I
Won't have
think
time to do it all.
I think, realistically, when you're starting, 1 to 2 a month is something to strive for. I think that gives you plenty of time to sit down, gives you like 2 weeks to go through everything. You got to get your models, you got to print your models if you're 3D, you're doing everything 3D. If you got to get the mounting, make sure the mounting's right. You're going through your 2D, your 3D checklists. Hopefully you're using Smile Wizard and you're got your photos and everything in one place. And you're sitting down with all this. Because I'll tell you, when I first came out, I was trying to do records on as many people as I could just because I wanted to get the practice. And then what do you have? You have a lab bench full of models and a bunch of patients waiting for answers. And so, I think realistically, you have to kind of say, what can I handle and what can I do and where do I feel comfortable?
I
Um,
call that the model factory. And
yes,
some people are waiting for answers, and some people that I had gotten into records couldn't even care less. They weren't even ready to hear it, and I just did it anyway. And
correct.
but it was my learning curve of realizing not everybody's ready for all of the information. And but everybody I still believe deserves the full exam. They don't necessarily need a full workup until they're ready to hear it. But everybody, in my opinion, deserves the exam. And that's classic Pete. Pete said every one of your patients deserves it. Does everybody necessarily get it? Well, they come in on emergencies. Maybe they don't get it yet. And that's what I keep in my mind. It's just not yet.
But
We're going to get there.
again, that emergency, that new patient emergency, that patient that's coming in for whatever the situation is, whether it's urgent or non-urgent, an emergency to them, it is a way to transition that patient into your practice. So,
Absolutely.
setting your practice, setting your standards, converting that patient, this goes this, committing to treatment is not life or death. Yes, patients can wait to do treatment. I mean, the one thing that as dentists, we don't have to tell somebody they're going to die, right?
Yeah.
They lose a tooth, may potentially lose a tooth. But we can kind of correct things. It's just when they're ready to do it, right? It's kind of we're kind of at the mercy of them being on board because if they're not on board, if they're not on the train, then it's not going anywhere.
There's a lot of resentment if you try to force them to do something they're not ready for. And if you do something that you're not ready for, you don't feel right doing, there's a lot of resentment also. So I completely agree. Going back to that patient, the new patient emergency yesterday that I did not repair the front tooth on, I talked about all this stuff and we didn't do the full Smile Wizard yet because it was an emergency consultation. The next visit will be this. But as they were leaving, I honestly didn't know if I got through. They said that, oh, they were going to get back to me with a medication list, and they didn't schedule as they were walking out the door. And I was like, oh, I lost one. I guess I didn't get the message across. I got an email today with the medication list.
Right.
And I was like, oh, I guess they were serious. So I was like, all right. So I did get through.
And
Sometimes it doesn't happen the way you expect all the time. I was like, all right. Yeah.
I'm sure Danielle is like just like my front too, when they do leave, if when they're not scheduling, we're following up with them too.
Yeah,
Is everything
absolutely.
okay? Can we help you? And a lot of times, just those little things that the front office does makes a world of a difference because not every office does that. Not every
Yeah,
office follows up and checks. And so
that's true.
sometimes it's, oh, I just forgot. I'm busy. My calendar is set, but I do want to come back. I want to be a patient. I want to get the exam. But yeah, like Raj said, Travis, the comprehensive, everybody gets in my office, coming into my office, everybody is treated the same and gets the same exam. And that is that first part of Smile Wizard. That exam is done on everybody. And I think we take 6 or 7 or 8 photos and the
Yep.
radiographs and all that. When they go to records, when we get to records, which I had a records visit today, when my staff is collecting records, we're getting the rest of the photos. We're capturing CR, I'm doing a lot of things digitally, so we're doing digital Facebook, we're getting all that stuff to kind of so I can start mounting and start playing around with things. But we're making sure everything is there and making sure the patient, you can tell the patient's on board. They're usually like today when I got done taking this, okay, so when are we meeting? When are we going to sit down and go through all this? When are we having our talk about this? That is great. He is on board. He wants a solution. Not to say his wife wasn't there too, pushing for it as well, but she wants him to get the work done. But you know, those are the patients you want to do records on.
Yeah.
I think when you're coming out of or you're in the curriculum or you're just coming out, I think that your cost should be reasonable and you should do it at no cost on a few people just so you get the experience.
Yeah.
I mean, you have to value your time and money, but you know, you got to make something, but you should be reasonable about it. And that's how you're going to get the experience doing it. But
I think my first 5 or 10, I think I did for free, and then this goes back to $2005. I think I started at $100, 120 or something like that, and I slowly ramped it up. But I actually, I believe that everybody deserves the ability to find out what they need. So I still keep my price low on it. I've got some friends that are charging thousands for it. I mean, I want to say my records visit is maybe 300-400 bucks, and usually that's enough that they feel like they're investing in something, but not so much that they are, scared not to do it either. So,
right, and
Do you?
I'm about the same, and I will say as well is if they commit to full treatment, I credit them back the $400.
yep, exactly. We do the
I
same
just
thing.
give it right back to them off the treatment.
Yep,
I mean,
yep.
you know, so basically and I say that to them. I say, listen, you're paying for my time to sit there and do all this work. And this is something I've been doing for a while now, and I'm very thorough with it. But if you do treatment, you know, I'm going to credit you it back. It's, you know, if you don't do treatment, then, you know, it's my time. If you do treatment, this is coming back to you. And they appreciate that. I mean, just those little things kind of are appreciative.
I leave that up to Danielle, but she also did the same thing once in a while. She said if she feels that barrier is paying the 300 or 400 bucks, she'll say, same exact thing. She goes, you know what, we could write it off the treatment. If that's going to stop you from finding the answers,
Right.
then we will credit that back. But we should still find the answers. So
I think that's a great way to handle that situation. I really like that. It does seem to me like that records appointment is, or that cost is sort of a barrier because I would
yeah,
look at it as if they're not willing, if they don't value their oral health, and some people just maybe don't, if they don't value that, I mean, that natural barrier is because if they're not going to do the records appointment, are they going to do, you know, Invisalign down the road, or are they going to do something else down the road? Most likely they won't. Is that kind of what you find?
I do find that is the case sometimes, but that being said, there's an unknown that we don't always get through to the patient about. We try to explain, like the exam, they're completely wowed, but sometimes they don't realize. I try to explain it to them that the records is the second part of the exam. The first part is all the stuff in the Smile Wizard that we got in that initial summary, but then the rest is compiled with that second visit, and not everybody gets it. It's probably something that I'm missing in how I present it. But
I think it really goes back, Travis. I think it really goes back to the way dentistry has been done for so long, outside of the Dawson Academy. Patients are used to single tooth dentistry. I mean, they really are. You know, they come in, half the time the occlusal issues I see besides generalized wear, I'm talking, you know, when patients have pain or discomfort, is coming because they had a recent restoration done. It was put in, it's in hyperocclusion, or they're hitting that tooth first, and you know, there's some occlusal issue going on. I had this with a lady yesterday, new patient yesterday. She switched dentists because she's having problems on the crown was high, and the dentist said, give it a month and see how it is. And so patients are so used to single tooth dentistry that when they come to an office that does comprehensive dentistry, that looks at the big picture, that can say, you know, not every dentist wants to sit there and learn about occlusion or understand the functional occlusion. You know, oral surgeons know all about surgery. You know, periodontists know all about the perio issues. As a general dentist, you know, our main thing, besides knowing everything, is occlusion. I mean, that's the foundation of everything. It really stems from that. And when you come from a single tooth practice where I say this to patients all the time. I was guilty on it in my beginning of my career, you know, doing one tooth, not thinking about the consequence of the other teeth, you know, labs putting in crowns that are not in occlusion at all, right? That's why you see
yeah,
all these they fit right like a glove, right? The first time you drop them in and it bites perfect because they're out of
yep,
occlusion.
yeah, it feels great.
Uh,
Yeah,
so I mean, this is this is partly to blame because of where we've come from or how we're trained to in school, because I don't think in dental school they really train you to be a comprehensive dentist. I think the big thing is educating the patient. And, some patients get it right away. Some patients, you can see the light bulb go on, but, it takes a little bit longer. And some patients are just never going to get it because it's not something that's a priority to them. And, those are the patients at the time when they ask me things, I'm always like, they always interview, senior citizen. They say, what are the things I would take care of, if I was doing it all over again? They always say my teeth and my feet. I said, teeth and feet. That's what they always say. And so, you look at when I get these 80, 90-year-old patients in my office that have all their teeth, I'm like, bravo, you guys. And they're like, how am I doing? I'm like, you're doing great. You're ahead of the curve. They're all there. You're doing wonderful. You have great hygiene for an 89-year-old. I mean, but I think we are we are the minority. I think comprehensive dentistry is a minority. It's a small group, depending on which facet, whether you're Dawson or Spears or where you fall in, how you do things, to the greater cause of dentistry. And so you have a lot of new patients that have never had it explained to them the way we're trying to explain things to them. And I think that
Maybe
makes
I would say that that same thing goes for not just in general dentistry, but in surgery and orthodontics. We see the same type of correlations. We have a handful of providers around us that do those specialty type treatments very comprehensively, and some that are not. I had a new patient in day before yesterday that saw a surgeon that said it's either injections or surgery. Those are your two options, and that was it. And the patient comes to see me through another third party, and I was like, wow, I completely disagree with that. That's like, there's a lot of gray areas there. It was very, very interesting. And the surgeon was good, but he's a high volume practice, had to get in and out. Those are your options. And
and you see that with orthodontics, because I always say,
orthodontics, same thing.
I say that to my patients all the time. When they come out of ortho, I said 90% of orthodontists only care about getting your teeth straight.
Yeah.
They're not looking at your bite at the end.
Yep.
And coming out of the Dawson Scholarship, I mean, I work very hard to say to my post or my patients who are either finishing ortho or post ortho, if you're finishing ortho, please don't have your braces taken off until I take a good look at everything.
Yep.
And if they're finished ortho, please let's equilibrate your bite, because I'm going to guarantee your bite is not equilibrated.
Yeah.
And these are things the orthodontists don't even talk to them about, because at the end of the day, people just want straight teeth. The teeth are now straight, but now there's an interference. Now there is a premature contact. Now there's a whole host of things that they have no idea about that's setting them up for failure down the road. And they wonder why sometimes they relapse.
I've had to have that
Well,
conversation twice in the last week, actually. And so, yeah, very, very, very interesting.
It's
well,
it's
and those teeth also are going to move.
Oh, yeah, absolutely.
exactly. And so, this is, and this all, I mean, it all goes back to, why we do what we do, why we do the comprehensive exam, why we try to get patients in the records, because the one thing you get is when you talk about equilibration is like, how are you going to do that? And I said, well, we're going to get records and we're going to do it on models, and we're going
Yep.
to confirm we can do it before we do it in your mouth, because I can print out 5 models and do it 5 different times and not damage anything. But if I go into your mouth with a high speed, I can put it back, but it's not what was there before. So, the way to convert it's really an education.
Yeah.
And I don't think, you have to go in knowing not every patient is going. I don't want to say like, you're not going to hook every patient. That's not what I'm trying to say. But not every patient's ready to make the bite. They're not ready to bite the hook. They want to some of them are just circling around the bait a little bit, just waiting to see when they're ready to go after it. Some of them, they come in and they're like, I want to take care of this before it gets worse. Those are great patients. And honestly, those are the patients that usually you can be pretty conservative with treatment, because
Absolutely.
they're ready to do it when they're seeing those first signs of instability. It's the ones that wait so long that the teeth are so worn, it's just going to cost them more. And unfortunately, that's one of the things I say, the longer you wait, the cost is going to increase. It's just, I'm kind of just honest with them. The damage is already starting. You can see the cut, you know, the cut in the arm, you see your bone, you see the dent in, it's already damaged. How much damage needs to be there before you want to act? That's a decision you have to make.
And I say something, my version of the same thing. I say basically, I'll always have solutions for you. They will just unfortunately get more complex as time goes
Yep.
on.
Yeah, that's exactly right. Exactly right. Travis, I know we've been talking for a while. It's I think 7:46 now.
Oh, geez, is there
I,
already?
I mean, we're
Oh,
not.
God.
We're kind of basically going through this. You let me know how you want to run this because I know you have some stuff you want to talk about too. Um,
Yeah,
are there,
we're about right there. Is there any other highlights you guys think you need to bring up in the last part of the presentation in maybe the next 4 minutes?
um, I think let me just thumb through some of these slides. Uh, yes, I think this. Oh, I just went past that, but I think one thing that just passed, sorry, is the periodic scanning of patients and
Yeah.
those. These are just ways to kind of show the patient. The one thing I like, I don't work for a line. I don't promote a line. My disclaimer, I don't work for anybody, but or don't promote anything for anybody. But the one thing I like about the iTero is it does have that time lapse feature.
Yeah.
We scan every single new patient at their comp exam. We can scan them throughout out time and then show them the time lapse of where is teeth shifting, the wear of teeth photos, just a basic photograph of the occlusion, right, Raj?
Just at least a handful just to be able
Yeah.
to monitor it. Years ago, it used to be all just photographs for us, and then a periodic set of photos. I trained an old hygienist to take a photo here and there. Now my hygienist, Andrea, I don't know, it's been almost a year. She started, maybe more, she started deciding to scan patients. She scans them about once a year just so we can kind of monitor things, and it opens up the doors to a conversation whenever the patient's ready to actually want solutions. It's
And
kind of
I'll
cool.
tell you, the scanners have gotten so much better. I know I'm now using the new Lumina, which
Oh, yeah,
the high def graphics of this thing is
that's
unbelievable.
amazing.
Patients are amazed by it. Patients love seeing technology. They love seeing an office that's not going to stick goop in their mouth anymore. They do not like alginids. They do not like TVS. They love the scans. Um, I think the just kind of going back a little bit with staff, it's really important that your assistants are on board with this. Your
Yeah.
assistants know how to take the photos. Your assistants know how to explain some of the basic. They don't have to be in depth, but it's very easy. They've been working with you long enough to recognize the signs of instability.
Yeah.
I mean, they should be able to, my assistant can scan and then point out things to the patient before I even get in the room. And which is great. It just sets that foundation. Those are the little things that leads to records. Those little
Yeah, my assistant will say like he might be concerned about this. He might be concerned about this. It's already planting that little seed even 5 minutes before I come in and say the same thing, and that blows the patient away. Sometimes if we all say similar things about an area, and we tend to do that, so it's kind of cool.
Yeah, and then one thing that always comes up is it was kind of the hand off the baton, which is I guess, you know, when you get done explaining to patients, offices do different things of how they explain treatment, whether it's going to be, does the doctor tell the fee? Does the front office tell the fee? I know, Raj, I think you give the global and then
I
Daniel.
give the overall, and then I let Danielle deal with all the kind of how we're going to actually do it.
Right. And I kind of do a mix. Sometimes I give the overall, sometimes I just let my front office kind of figure it out for them. I kind of gauge it on the patient. Some patients just, they'll say whatever it's going to be, I'm going to do. And I really don't need to explain. I just hand it off to my front office. She does a great job breaking it down. Sometimes they just like, how much is this going to be? And I say it to them and they say, I just can't do that. And then we say, okay, well, let's figure out how we're going to phase this, how we can do this over time. One thing we didn't touch upon was phasing. It's a whole nother topic when you get into explaining treatment because not everything has to be done at once. I mean, we can phase things in provisionals. We have great long-standing temporaries, 3D printed, milled, all that stuff. So things can be phased over time.
The phase cases, and sometimes I've got a handful of cases that took 15 years or
Yeah,
more.
I think it's planting seeds and following up with patients. That's the key. I think for those patients that are not yet doing records that need to do it, it's what, planting the seed at hygiene, having the
Yep.
hygienist plant the seed, your morning huddle, you're looking, you're saying, oh, Mr. Smith is coming in. We know he has a lot of wear, just, casually, let's talk, let's see where he is. Is he ready to
Yep.
do something? And then following up with the patients. I always say to patients, whenever you're ready, I'm going to be here.
Yep.
I'm going to be here for another 30, 40 years, the way I'm working. So I'm like, go ahead. When you're ready, I'm ready, and sometimes it's just getting them into a occlusal split. And once you get them comfortable in that, it's very easy to say, well, that's the goal. The goal is I got you comfortable, is that you can be comfortable all the time and you don't have to wear the split. That's what
Yep.
that's the goal. That's what we're trying to do. So I don't want to keep going, Travis, because I think Raj,
We could keep on going. So let's.
Yeah.
uh,
Excellent. Well, I appreciate you guys' comments. That I think is very valuable, and I think people are going to get a lot out of this. If you want to let me share my screen,
yeah,
Steve,
so I'm trying to get out of this and um oh my mouse, where hold on a second.
I sent a request. I don't know if you see that.
I do. I'm trying to find my mouse. It's right here. Hold on 1 second. Hold on. Hold on 1 second. I'm having some technical difficulties all of a sudden now. Here we go. Okay.
Oh, there we go.
I'm just gonna go back to you and make you the host.
So can you see my screen here?
Yep.
Yeah.
Okay, so the new functionality is all around the all important, what we just talked about, the images that are coming in. And so this is not live yet. This is going to be live probably in about 4 or 5 days. And I'm going to show you why it's not live yet. There's just a couple of things that we're going to change. And this is just sample data. And so if I go in here and well, let's see, yeah, and I want to choose a photo, for example, and there's two ways to get this photo in here. I can just click on choose photo, or I can just drag and drop it in. But let's say you have somebody and you've taken an image, and this is perhaps what the image looks like. You now have the ability, or you will soon have the ability to rotate. And so there's an extra button here on this that we've just added. When you click on this first one, this is going to allow you to draw. If you're talking to the patient or somebody else, you can point things out, you can circle things or whatever, and then you can undo it and or redo it. This is a function. This is some functionality that's actually been there for quite a while. And you'll notice in a lot of the tools in Smile Wizard, you've got this horizontal bar here. If I was to take this and try and line this photo up, you'll notice that they're not even. If the eyeballs are not even, then the chances that the photos are even are not good. And so we're adding the functionality now to be able to rotate that. And the ability to do that is actually on a different screen. So that's one of the things you should this is one of the changes that need to be made. This tool here is actually going to show up on this button. This is the rotate button, but it's not there yet. So if I click this button now, I have expanded functionality. What I would normally do is bring that tool down and look at the eyes and see how close they are. I would then be able to rotate it to the right, as you can see there,
Oh,
and it
nice.
looks like it's
Okay.
about right there. That would be a better ideal smile. And so then you'll be able to save that photo, and it will actually save it out to. And what it does is it replaces it, and you can then, this will obviously be used downstream. So if I go, for example, and again, it might take too long to do this, but if I go into here, yeah, it's going to take, because it's going to, the good thing about Smile was it forces you to go do things in the right order,
Got
right?
to do the steps.
But then it basically will go downstream and you'll be able to see it down there. The
Cool.
other thing that's being added is, and this is all based on user feedback. So I've got people telling me these things and suggesting these things to me all the time. If you double click on this photo, it will basically bring it in full screen.
Yes.
So I think Raj,
Oh,
you were one of the ones who wanted this,
I
and it's
love it.
great feedback. And so and again, we used to just have it like this big, but now if you double click it, it's going to go full screen. So
Sweet.
I think those things are going to be very helpful. Oh, and you also have the ability when you edit it this way, you can mirror against any axis. This
Oh,
Great.
typically only comes in handy with these upper occlusal and lower
yeah.
occlusal, where I think you use the mirrors to do that. And
Mhm.
a lot of times because you've done that, they come in backwards or mirrored, and they shouldn't. And so you'll be able to do that as well.
Or the profile.
Um,
Sure.
Or a
yeah.
profile
Yeah, the
sometimes. Yeah.
profile. Sometimes my system takes it the wrong way.
Yeah. We've had it too. Yeah.
Okay. Yeah. And so basically any of these will work. And
Cool.
So that's about to release. Like I said, this it took us a little longer than we thought, but we have also figured out some other things later on that won't come up as issues anymore for people. So, and again, you can drag and drop these images in here if you want to. So just wanted to put that out there for people. It's going to be live, like I said, probably in about 4 or 5 days once we get the tool fixed that allows you to kind of see horizontally. Any any questions about that? Okay, I don't see any coming in. I don't want to necessarily keep people too long. We really appreciate your guys' participation. Thanks to both of you guys for putting this thing together and talking about it. Like I said, very important issues, and we really appreciate the support and but especially the users. So this is good stuff. All right. Thanks everybody. And we will, oh, do you have anything coming up? Do you want to talk about your study club?
Steve?
We have a program in, I think from what I saw, it was an invite-only program, practice management, with the Dawson Academy. You can reach out to the Dawson Academy. I believe there's 8 seats left for it. It's going to be a practice management based 2-day lecture in New Jersey at Raj's lecture facility in East Hanover. Speakers will be Larry Gazzardo and what Rachel, I forget her last.
Rachel Carfeld.
Barfeld, thank you. I
Yeah.
was going to say Cart. Um, they'll both be speaking. It's a new course that's coming out for the Dawson Academy, so it's for a limited audience. So if you are interested, I would say reach out to the Dawson Academy and sign up. Again, it's August 1st and
Or
2nd.
second. Yeah.
It's the Friday and Saturday in New Jersey. I think it's 15 hours of continuing education credit.
I think so.
So it should be a great course. Um, yeah, that's pretty much what we have going on, or what I have going on.
Yeah.
Okay.
Same.
Well, I appreciate that. And all right. Thanks everybody again. And we'll talk to you soon.
All right. Thanks,
Have a
guys.
great night.
Thanks,
Have a
guys.
good night,
Bye bye.
everyone.